all protocols are observed. Of Somali in the world, the military shirkan. Yeah. Okay. Although I was expecting to have this keynote speech early in the morning at 8:30, but I got the privilege to learn a lot from the presentation. First of all, I would like to extend my gratitude and appreciation to Abrar University, the organizers of this second Somali One Health conference. I just wanted to present something that we learned a good thing from a disaster, from a crisis. Everyone knows what COVID-19 cost the world. So how we can leverage, how we can learn lessons about such crises and outbreaks that can happen. Everybody knows that talking about COVID-19 pandemic, COVID-19 era, COVID-19 outbreak is simply an one health issue. Simply a disease came from a zoonotic disease, and then immediately spread out of the world and causes a lot of crisis, not only in the health sector, but also in the entire sectors. So, as in Somalia, how we manage, how we cope with it, what kind of lessons that we can learn from such epidemics or pandemics when it comes to happiness, how our fragile health systems be equipped. So all my presentation is on that era, on that situations. COVID-19 hit us, Somalia, when we were in our most vulnerable situation when it comes to fragility. Our health system was very weak. Healthcare industry, everybody knows in terms of regulation, service delivery, in terms of medical practices, especially specialist cares, public health services, and private. The service provision was limited. The ICU capacities, all of the country was nearly 20 bed capacity in our ICU. The specialized medical treatment at Medicare was very rare. The medical products, especially pharmaceuticals and medical communities, were inadequate. And it surprised us as it did in all of the world. First, when the case was identified in Somalia in the middle of March, there was no hospital was ready to cope with it. And beside the issue of COVID-19, there was also a panic was going beside the issues. Infodemics, the people were in queues. Nobody was knowing what to do. And hearing the COVID-19 also was similarly hearing also the death. Our emergency preparedness and response was not in place. There was no contingency plan, there was no emergency preparedness. Simply, there was no interlinked institutions, like one health institution should be in place before such a scenario happens, there was no also in place. So, it was a lot of a scenario. I don't want to go deeply inside, but we learned a lot from it, as also the world learned from it. Welcome, Ali. If you're we will examine how our situation was, then what we tried to do and what we can learn from, when it comes a pandemic, in globally there is a means and tools that should everyone adopt it. So in Somali case, we don't have even an idea about that. The outbreak investigation, outbreak mitigation, outbreak response and plans and so on, there was no in place. Our healthcare infrastructure was very poor, really. Accessibility was a big issue. Lab and tests, medical labs We were sending the samples, first samples into Nairobi and South Africa in the first cases. There was no risk communication and community engagement. As I was saying, there was a lot of infodemics, a lot of misinformation is going on with the disease. Our public health parameters that meant to deal with promotion and prevention was not also in place. The surveillance system, حدث عنه ولا حرج, there was no adequate surveillance system. The IHR was not in place in our country. The early notifiable diseases were not even was not getting enough reports from only the major cities in the federal member states only. And along with the other issues beside the health, there was a conflict, there was a flood, and droughts, and so on was going on. So we learned from one such a crisis suddenly happened to us, surprisingly. Now it comes the importance of One Health here. Having a platform together with the different knowledges that deals with from grassroots level, from the crisis that before it comes into the world. This is the aim that I wanted to suggest. We learned from COVID-19 pandemic that the coordination mechanism was a life-saving tool, was an equal to or similar to the life-saving tools was provided inside the ICU and emergency. So the coordination, preparedness and plan, having an institutionalized centers that deals with pandemics, outbreak investigation, outbreak management, having public health emergency operations centers, having the means of that public health emergency operations centers which have an active mode and watch mode depends on the scenario of the outbreaks was the heavy elements that we learned from COVID-19. First 60 days, there was a meeting was chaired by the former Prime Minister, and I'm very much happy to see Dr. Fuji, who was our Chief of Medical Officer at that time. We were discussing every night what is going on. And the people were dying, sometimes 70 cases per day was dying. I was appointed to be a director of the Martin Hospital. There was only 20 beds at that time. And the second or third day, we received nearly 100 cases. So you can imagine how there was no single ICU bed was publicly operating in Mogadishu. Most of the private hospital was just shut down because of the fear. The fear of contagious, the fear of COVID-19 was really very high. So coming together, putting plans together, developing the contingency plan in 1 or 2 weeks, engaging healthcare professionals. I fully remember the Somali Medical Association drafted the first action plan of COVID-19. The healthcare providers of private sector, they provide the first lab that was tested COVID-19. We were testing COVID-19 Somalia before Liberia and Libya and Tunis and Burundi because of our strong private sector. So coming together and institutionalizing the pandemic issues was one learn. Today, as we are in One Health, in order to be fully prepared to take these lessons into actions, we have to have a well-equipped, standardized, that can cope with the World One Health scenario, that can assess before such scenario happens. This was the total confirmed cases, and there was a lot of non-confirmed cases in Somalia. There was a report coming from the graves and everywhere. Those reports are only from 4 to 5 major cities in the country, where there is nearly 90 districts with no report. The community engagement was very limited at that time. What we did in the COVID-19, we focused on 3 scenarios. First was coordination, resource mobilization, building resilience, capacity building, development, training. Now we have a lot of cadres who can deal with emergencies, critical care services. We engage our partners to do. So we learned a very good and useful essential medicine, which is an oxygen. Nobody was knowing that before COVID-19. Now we use the oxygen plants to treat the pneumonia, which is the leading cause of death in Somalia. One of the benefits that we get from COVID-19 was implementing the oxygen plants, getting well-professioned cadres that can focus. We learned that the importance of radiology, the CT scans into the health systems. We explored a lot of innovative ways that can save life more. So investing in human, focusing on coordination, focusing on building resilience. What was the COVID-19? Everyone, the richest person and the people from the IDP camps, they were in the same ward. There was no airplane. The minister, there was a senator, an MP, and a highly well-known businessman, and people from the different were treating and getting their treatment. So COVID-19 tells us, what we was missing in the normal life, the equity or equality in healthcare system. Tells us when such scenarios happens, it touches you. There's even if the president was cut, couldn't travel outside the country. So we learned to preparation and having a platform or mitigation plan that you can switch on, it will save more life. This was the situation of distribution of hospital beds across the country. I was an incident manager at that time. Now, you can see those centers for COVID-19, now they are dealing with emergencies, the critical care is, there is anesthesists, respiratory therapists, emergency specialists there. And now there is an ongoing project called Critical Care Unit, was meant to have every state have 1 or 2 standardized hospital that can deal with the emergencies and outbreaks. We improved our supply chain management, and was a big issue. The BPEs was an issue, and so having an LMIS management of supply chain management was also a lesson learned from COVID-19. Capacity building, focusing on human as a change makers, as a life-saving agents, improving surveillance, disease identification was a lesson learned from the COVID-19. Thank you so much.